So before we get started, I just want to give you a little bit about me so you'll maybe understand how my brain works, and hopefully that will be helpful during the exam and stuff, and as we navigate this very poopy journey together. So active duty PA, right? Did the Force Com, which is operational medicine, occupational medicine sort of thing. But then I did a stint as an internist, as a hospitalist for a while. So it was in inpatient medicine. And that even transferred to when I was here, I was doing outpatient internal medicine. And so I'm very biased towards the internal medicine way of thinking and way of looking at problem sets. So you'll see that come through during the lectures. Another thing about these lectures, I'm going to point out to you what is different. And you need to pay attention to it. I'm going to be very deliberate, like, hey, this is something that's different. Pay attention, because that's how I'm able to test you, right? I'm an expert in multiple choice question exams. An expert in it, right? Doctorate in education, that's my thing, the test committee chair. Like, I'm a baller, all right? Telling you right now. So if I'm telling you that something is different, you need to hold on to it. You must hold on to it, because that is going to be one key way that I make distractors to distract you, right? To make you choose an incorrect answer. And when there is no difference in certain pathologies and etiologies, I'm not able to test you on it. Well, if it requires me to utilize 10 to 15 variables to point to one diagnosis, probably what's the point? What's the point? But I'll show you where it's critical. I'm not going to stomp on the ground. I may dance, but I'll let you know there. Okay, let's look at a few things for housekeeping. Okay, so this is the Canvas page. I did a little bit of housekeeping. I noticed that my PDFs didn't transfer, so I'll make sure that those get uploaded. But if you click on the block 1 content, you should see at least, at a minimum, all the PowerPoints. They're all there for you to download. I like to confirm the PDFs because I know some of you guys utilize software where PDF is better. So I put that up there for you. But this is our course page. Right? How do you contact me? Canvas. Don't be lame. What I mean by that is, like, don't spam me with a bunch of stuff. Right? As we get closer to the exam, especially because our first exam is after a holiday. And I'm going to be in Canada. But trust me, I'm going to be religiously looking at Canvas, looking for questions, all right, if you guys have them. So I don't want to bug them. When it's time for the exam, you better, I'm trying to say it word as much as I can. You better freaking bug me, okay? You better bug me, because the first exam sucks. It's not great. Some of the stuff is new, right? Some of the stuff is new. The second exam, I'll give you some new material, but a lot of it you will have heard elsewhere. This first exam is very definition-based on this thing. And maybe for some of you, you're like, no, I know what this was the whole time, right? A diagnosis of exclusion, got it, right? But for a lot of you, I know that are non-medical, this will be a new way for you to be assessed. But okay, so that's there. The other thing I wanted to point out to you, and it's this thing down here, it's our tentative schedule. So I got screwed over somehow with the schedule. Like, I'm always in like the last block or the first block of the day. Like, I like the sweet spot, like the 10 a.m., the good one, right? I'm always good at that one. I suck at these other ones. But this is all tentative, right? So I just recommend just download everything, right, tonight. Just get it all on your devices, and I'm just gonna go at my own pace. So I did this for the first time at IPAP last semester, and I found I was finishing way early than the time that I was given. And so I would rather finish earlier in the semester versus earlier in the day for you guys. And that's what I've outlined here. So this is all tentative, so just download everything, just be ready to rock and roll with the stuff. And if you looked at the please read, the read ahead stuff, cool. If you didn't, I don't know, okay, it's also fine. Like, I'm telling you probably know this stuff, and if you don't want to know it, also fine. I'm not testing you on it. Let me move this thing, sorry. People will bug me about your orders all day. So yeah, so that's up there for you guys. And where's the recorder at? There, okay. Is there a camera?
Yes.
Where is it? There, okay, good. Last time it was like almost inching towards me and I just didn't want to be in it. All right, that's cool. Yeah, so you have the recordings as well, which should be fine. Contact me via Canvas, especially right before exam. I'm also going to try, I'm not going to try, I am going to show you at least 3 exam questions. How I'm going to assess your knowledge. The caveat with that is that there are questions that we'll never use in IPAP again. And I'm showing them to you because they're probably crappy. Okay, there's probably like, hey, there's a dual credit or a pan credit or something to that effect, and so it just drives the conversation. So I will provide you that as well. But this is not a one sentence exam, right? Where you get one sentence and you just have your immediate recall. That's not where we are. We are in the medicine realm now. Now it's all vignettes. Now expect that your average time for my exam will be about 50 minutes. That's where you should be. It's a sweet spot. For the pants, you get a minute per question. If you're at a minute per question through your first look, well, I'm doing okay. Right? But if you end up taking the whole 75 minutes because of tech issues or maybe you're really mulling stuff over, also completely fine. We just expect that maybe it's going to take you a bit longer, okay, to get through these vignettes. Questions on any of that before we get started? Don't talk to me about face stuff at all. Okay. Not while I'm up here. You can do that elsewhere, because I'll get really angry, and then we won't have a conversation with each other, which is not good. Okay. So let's get started. All right. So this is the intro, part 1. A lot of the questions stamped, and this goes not only for GI, but for all of these courses, is that we're going to provide you information, and as soon as you read the first sentence and or second sentence, you should be beginning to form a differential on what the heck you think this is. And by the time you get to the end of the vignette, you should have a good idea. It's either one of 3 things, and that's what we're also teaching you to do in ClinCore, right? You get a chief complaint. You get some bit of knowledge, you should immediately be thinking about stuff. What could this be? One pro tip, while you're in GI, think of GI differentials. Not bad, right? That's one thing that's nice about the didactic part. You don't have to really focus on what's going on here. Another thing that's nice about GI is it can be directional. It can be a map to what organs involved. If they have pain, where is it? What's located behind that? And maybe that organ is the proximate cause for their symptoms. And let me show you some examples. Right, so you can cut the abdomen and the thorax in multiple different ways. So you have the quad, you've got the 9 thing, in different ways. Cool, all nice. What's even better is this one. This is now putting a diagnosis with chief complaint, with presenting symptom. To get an idea, if you get someone with left upper quadrant pain, what should you be thinking about? It probably shouldn't be appendicitis, right? Probably shouldn't be, okay? But possibly the stomach, possibly something duodenal. Left lower quadrant pain, things that are top of mind. Some type of diverticulitis, diverticulosis, and that'll be block 2. But this picture, for me, is a nice way of me understanding, okay, if they've got pain or some type of symptomology in any of those quadrants, what diseases exist there? Okay? It's not 100%, it's not even 90%, I'll be honest with you on some of that stuff. But it's a nice framework to start with. Okay, so this is what we're going to talk about. Dyspepsia, nausea and vomiting, hiccups, and then burping and farting. Okay. Dyspepsia, what is it? It's a symptom, okay? It is not heartburn. It does not equal heartburn. What it is, though, is that epigastric pain, the burning, that early satiety that patients will experience, that postprandial fullness, or they eat a meal and now they feel extra full. Etiologies, there's a food or a drug intolerance, so indigestion, acute, self-limited. Maybe they ate too much, maybe they ate too quickly, possibly eating when they're stressed. There's other alcohol, caffeine, all those things, medications, NSAIDs, etc. can all cause those. But what is functional dyspepsia? So this is now a diagnosis where no organic etiology explains their symptomology. So in other words, and all the other things we're going to talk about later, you'll have done the workup, and all that stuff was negative. There was no organic etiology, there was no H. pylori, etc. They had now functional dyspepsia. And again, the diagnosis of exclusion. And it's the most common cause of chronic dyspepsia. Diagnostic criteria, this is pretty straightforward. And this kind of looks like a DSM criteria, but don't get too in the weeds on this. Understand this is a diagnosis of exclusion. So really what we need is the bottom part. It's that and. And there's no other explanation. And the rest of this course is going to give you explanations as to why a patient will present with just general dyspepsia versus functional dyspepsia. Here's some organic etiologies. We're going to hit on all of these. So we've got GERD, we've got peptic ulcer disease caused by H. pylori. Maybe it's cancer, neoplasms, lactose intolerance or malabsorption, like a celiac disease, celiac sprue, or gastroparesis due to diabetes. Now, you guys haven't gotten to that part in endo yet, but endo and GI overlap quite a bit. We'll talk about thyroid disorders, right? Hypothyroidism and constipation here just very shortly. I mentioned H. pylori. Parasites can cause dyspepsia, pancreatic, biliary tract diseases, and then a variety of other comorbidities. So I mentioned diabetes, and that's because of delayed gastric emptying, thyroid disease, chronic kidney disease, or an MI, right? MI. That's why folks present epigastric pain, dyspepsia, that issue. We have to consider if there are certain names, certain comorbidities, that this is acute coronary syndrome. Clinical findings, chronicity, location, quality, duration, those are things we're absolutely asking about relationship to meals. And the purpose of this slide is that these are questions you should be asking in general because they're going to point you to more organic etiologies. What's their diet like? How much alcohol do you have? Caffeine? Are you eating spicy foods and then you get the symptom? What meds are you currently taking? Have you had any changes in diet or exercise? Some psychosocial stress. That will become important when we talk about irritable bowel disease. Other potentially serious symptoms. Do they have a fever? We're asking that all the time, right? And every single patient, it's a general part of our review system. We're asking about fever, chills, weight loss. Okay? And then because this is GI, we're going to hold up the holy trinity of nausea, vomiting, and diarrhea. You should ask those together every single time. That is a holy trinity. Alarm symptoms. These are red flags. We see these things, we need to do something else. Unintended weight loss, makes sense. Dysphagia, what does that mean? That's painful swallowing, painful, okay? Recurrent vomiting, evidence of a bleed. You find that the patient is anemic for no reason and they have dyspepsia. That's a red flag. Genetic loading due to family history, or onset of symptoms greater than 60 years old. Because now we're in the Jerry's. And also we'll teach you guys geriatrics next semester. Who gets cancer in this country, in this world? It's the Jerry's, right? More likely than not. And so you get an older patient with this new onset symptom, you better be thinking cancer. You must be. That's what this is saying. Physical exam, generally not useful. Typically unremarkable, unfortunately. You may get some mid-epigastric pain on palpation. Here we're looking for pertinent negatives. What's not there? What's not there is jaundice. They don't have lymphadenopathy. They have no cachexia, have no pallor. There's no organomegaly. Because if there are those things, we should be thinking something else. We're probably thinking now organic, not functional. How are we assessing? Getting a CBC. Why? Anemia. Yeah, we're looking at their red blood cells. Right? That's the principal reason I'm looking. Okay. CMP. Why? Liver enzymes. What else? And electrolytes. Absolutely. Okay. Amylase, lipase, we'll talk about pancreatitis in the second block. Thyroid panel, okay, well, they could be hypo or hyper and have dyspepsia. The thyroid does things to the gut. In hyperthyroidism, they're pooping their brains out. In hypo, there's delayed gastric emptying. Okay. Both can cause dyspepsia as a symptom. H. pylori antigen testing, we'll hit this in a second. And then other tests, we'll have entire lectures on celiac disease, antibodies, and then we'll touch briefly on stool for open parasites. Upper endoscopy, EGD, UGI, lots of different acronyms. I'm going to do my best to spell them out for you on the exam, okay? So that you won't be guessing on what I'm asking you to perform. But an EGD, know that when I'm speaking to you, I'm talking about an upper GI series versus a lower GI series. But who's getting that? You've got signs and symptoms suggestive of etiology other than uncomplicated dyspepsia, like the red alarm, the red flag symptom I just mentioned. Or they don't get better after just some pure treatment, like a PPI or something. Probably need to do an EGD. Again, anybody greater than 60 years old, new onset symptoms, anybody with an alarm symptoms that I mentioned, they are getting scoped, okay? And what is that scope? It is the esophagogastroduodenoscopy, or EGD, that's the actual name for it. And this is done under sedation. They put a block in the patient's mouth. They take this long, flexible camera, and you stick it down the throat. And we're observing from the external orifice all the way down into the duodenum, looking, observing, taking pictures the entire time. Another thing that's great about this procedure is that you can also pass tools through it. And we'll talk about several different tools we can utilize. There's things like ERCP, you probably remember from radiology, but we'll actually show you some pictures of what that looks like and why it actually is indicated for GI reasons. So differential diagnosis for dyspepsia. Welcome to the GI syllabus. Okay, you're going to learn about every one of these diseases, how they present, what the schema is behind these patients. And it will be obvious, trust me. You'll have an idea because these patients walk in and look a certain way, they sound a certain way, sometimes they smell a certain way, and I'll hit you on that, I'll let you know when that's actually relevant. But all that stuff is there, so cool. Empiric treatment for dyspepsia. Younger than 60, no alarm features. We don't think there's any organic cause. We think this is functional. It's completely fine to go ahead and screen them for H. pylori, start them on a PPI. You put them on that PPI for 4 to 6 weeks. It should improve. Now, do they stay on that PPI forever? In real life, they do, right? But you're not supposed to. You're not supposed to, right? You do the trial and then you wean them off. There's several studies out there that show PPIs have a relationship with early onset dementia, with chronic kidney disease, diabetes, all the crazy things that are out there. People stay on these things for extended periods of time for no reason. So, again, I'm transitioning over to my internal medicine hat, my Jerry hat. You have to be comfortable when you're seeing older patients on a PPI, pruning that medication off. Why are you still taking this? You still get L6 on it? Yeah. Right. But you'll see what happens when you don't take that anymore. There are some other things we can do within your lifestyle to better suit you. Because now there are true, legit risks if you continue this medication versus you feel a little in my tummy versus now you're demented. Okay. All right, switch gears. So what is H. pylori? And we're going to have even more of a conversation about this bug. It's a fun one. Right? Spiral, gram-negative rod, resides adjacent to epithelial cells at the mucosal surface and in gastric pits. It is a common cause of peptic ulcer disease. And who do we test? Dyspeptic patients, chronic GERD patients. If they have peptic ulcer disease, they're absolutely tested for it. And there are 3 main ways that we assess that. And I say that in jest. There's really 2 ways. Okay. The third way is there, it exists, but we don't utilize that as good clinicians. We know it's bad. But the best way, the principal way, is the way that's highlighted. I need you to poop and give it to me. Right? That's what I need. I need your stool. It's the fecal antigen test. And look at that specificity and sensitivity. That's pretty darn good. Right? 98%, 94%. It's solid. Right? I get a positive back on that, you got it. 100% you got it. It can also be used to test post-treatment eradication. We're going to get into some nuances on this because some of the medications that the patient may be taking for their symptoms may confound this test. And one way that we do empiric treatment for GERD or dyspepsia, we just give them a PPI. That can confound the test and make it a negative. So you have to talk to the patient about stopping the med for a week, and then they poop on a stick for you. Okay. Carbon-13 urea breath test. Sensitivity and specificity similar to the fecal test, but that needs to be, it's an outpatient procedure, but they need to go into the clinic and do it. Not every place has this assay available. You could do this urea breath test, carbon-13. And then the H. pylori serology. It's quick, it's easy. Sensitivity and specificity is super low for both of them. So just don't order it. Just don't, okay? I will put this on as a distractor. If one of you select it, I'm going to make fun of you, right? I'm going to tell, like I'm here, standing right here, telling you don't select this. If you do, you're going to get made fun of, and I'll be joyful. Okay. So how do we treat it? Two main ways. And this is a heavy pill burden. I want you to take that into consideration when we're talking about giving medications to human beings. Know that the more medications that we provide humans, the less compliant they are with it. And I'm telling you right now, the way to treat this is with multiple meds. And the triple therapy is going out of favor. Now, and again, we'll hit on this later, but now because of some of the resistance, everyone's gone to the quadruple therapy. And what is it? You've got a PPI, BID, twice a day PPI, Pepto, 2 tabs, 4 times a day, tetracycline, 4 times a day, and then Flagyl, 3 times a day. Oh, wow. Wow, I had to do that. I had H. pylori, I had to do it. I was like, this is crazy. Like, this is a lot. Like, I'm good at stuff, and like, this is hard, right? It's really difficult to ensure that you're solid. So that's why testing for cure after the fact is a thumbs up. Okay? But again, it's recommended that quadruple therapy is where we start nowadays. Okay? That's why it's asterisk there. We'll talk this again in greater detail later. So again, once all organic causes have been excluded, we talk about some general measures, lifestyle changes, discontinue their alcohol and caffeine, eat smaller meals, keep a food diary, sure, right? I'm not sure this will all work for them. But limited efficacy, right, with these other things. So we could do the empiric therapy with the PPI, but maybe it doesn't work. Because what are we treating? We don't know. There's no organic etiology. We're just like guessing there. Tricyclic antidepressants, know that in medicine, when we're at the level of the TCA, we're probably playing jazz, right? We're out of the science at this point. So like, yeah, maybe, try TCA. Try a prokinetic like Hilpamide, Reglan. And then there's psychotherapy or CBT to help them with their functional dyspepsia. Question on dyspepsia? No. All right. Turn my phone into focus so that people stop texting. Sorry. Nausea and vomiting. Here we go. This is good stuff. As long as it's not happening to you. All right. So nausea, I think the worst symptom ever. Like I've had a lot of bad things happen to me. This one I dread all the time. What is it? It's that intensely disagreeable sensation of sickness or queasiness, and it's not anorexia. Right? Anorexia is decreased appetite. We're not talking about that. But they probably could eat if they were not nauseated. And then vomiting. What is that? That's puking, barfing, blowing chunks, right? Spewing, retching, that's spasmodic, respiratory and abdominal movements. It is not regurgitation. And regurgitation will become important later when we talk about disorders of the esophagus, okay, and some Zinker's diverticula. Common causes, number 1, in bold, numerous serotonin 5-HT3 receptors. And that's one main way that the body is induced to vomiting, or the body is induced to having nausea. You recognize possibly a medication that's mechanism of action is to combat the 5-HT3. It's a beautiful medication. It's the best. Zofran, right? It's the knight in shining armor. It's beautiful. It's so good. It comes in multiple formulations. Right? IV, IM, PO, oral dissolving tab, per rectum. We can do it any way you need to go. Right? It's so great and works. And I'll tell you, this is a clinical pearl. If they're already actively throwing up, good luck. Probably not going to work. Right? But if they're still just on the nauseated side, they're going to thank you. It's heaven. It's Zofran, so that's a beautiful med. It should be in the water. It's so good. And then you can see those other reasons, right? Stimulation of fibers and the vestibular system. Smells can make you nauseated. There's chemoreceptor trigger zones, so that's why people that undergo chemotherapy might be nauseated and start vomiting as well. But here's some things we need to talk about and ask about. Are you having any nausea, vomiting, or diarrhea? Okay, cool. Are you having nausea? Are you having vomiting with it? And ask it again, right, just to make sure. You're having nausea, are you having vomiting? I'm now clarifying what the heck is going on. If you are vomiting, what's it look like? Is there blood in it? I'm asking that question specifically. You notice blood. Is it super dark? Is it coffee ground-like? None of that. Is the food digested or not? Is it just bile? And most patients will know what that is. Is it just yellow? Is that what you're throwing up? You get nothing on your stomach? Is it in relation to meals? You find yourself eating and then you immediately have to vomit. Is there abdominal pain? 100% I'm asking this question. Do you have pain in your belly? Where? Point to it. Great. Differential for me. What meds have you taken? You changed your diet recently? Have you had any sick contacts? Other GI systemic symptoms you actually been asked as well. So, some ways to look at this. You've got acute onset without abdominal pain, you can think food poisoning. Now, is food poisoning a real diagnosis? It's not, right? It's not really like type that in as a real thing. There's a reason, right? And likely it's a virus, right? They got a virus even at the taco truck, right? It was still a viral transition there. We cook food well here in this country for the most part. Do we have cases of outbreaks? Yes. But do we call it food poisoning then? No. We call it by the pathogen that caused the symptoms, right? Okay, so understand it's not a real diagnosis. When we say acute gastroenteritis, that'd be fine. Systemic illness, so again, no abdominal pain there. Acute onset nausea and vomiting with abdominal pain, just some peritoneal irritation, just an acute obstruction, maybe some gastroparesis. And if they have early morning vomiting, one, are you pregnant? Do you think you could be pregnant? How much alcohol are you drinking? Really, those are the two big reasons for our morning when we wake up and throw up. Okay. Physical exam, here's what we're looking for. We're doing an HEMP exam. We're going to. Because I need to look at your mucous membranes. Are they dry or not? I'm evaluating your level of hydration. I'm looking at your skin turgor. I'm assessing for orthostatic hypotension. I'll talk to you about orthostatics here in a second as well. On my abdominal exam, is there any tenderness to palpation? Any distension? Any organomegaly? And I'm not palpating the freaking liver. I'm not trying to find that. I'm just putting my hand in there. But does I feel anything weird? No? No organomegaly. You feel something weird? CT. Okay? You feel something there? They get the CT. Or they get an ultrasound. Just keep that with you. All right, so let's talk orthostatics. Sometimes this is incorrectly described as the TILTS test. This is not a TILTS test. Do not describe this procedure as TILTS. That is a cardiac procedure. We're talking orthostatics here, to assess for orthostatic hypertension. The main so what with this, and I don't want you to memorize this, is that we're measuring blood pressure and heart rate in 3 different ways. While they're sitting, while they're supine, and then while they're standing. And then if we see any big changes, right, in their measurements, like, okay, you have orthostatic hypertension. You are dehydrated. Right, this is a way that we can assess that. Another way we can assess that. I look this up every single time. Okay, you're not going to be tested on this. This is for you, for later. But know that this is orthostatics, looking for orthostatic hypertension. Labs, not always indicated, especially if it's acute. What am I going to do? Well, what could you do? CBC. Why? Signs of infection, possibly, or signs of inflammation. Right? That's what we're looking for an elevated white count. Also looking for RBCs, maybe if they do have a bleed, right? So that wouldn't be a bad idea to look there. BMP, CMP, and it's giving you the answer to the test on that one. We're looking at electrolytes because they've been vomiting a whole bunch. Maybe it's bulimic now. What's going on with the electrolytes? What's their glucose look like? Look at the liver enzymes because maybe it's a hepatitis that's causing their symptoms. Right? We'll get to that in the second block. Getting an HCG on your patient, right, if it's indicated. And are we always doing radiographs? No. But are you wrong if you just do a KUV, a plain abdominal film? Not wrong, but you don't need, it's not going to really tell you yes or no on a lot of stuff. Okay? Same thing with the abdominal CT. If you're thinking abdominal CT and we're talking about the belly, we're thinking about surgery. That's the reason that we're getting it. Complications, so dehydration, hypokalemia, I mentioned that. Metabolic alkalosis can occur. You can get an AKI just from throwing up a whole bunch because you will be dehydrated. They can aspirate, which if they're an alcoholic, right? We think about the Klebsiella. Boring syndrome we'll hit on. Mallory-Weiss we'll talk, those will all have their own separate sections and PowerPoints ahead. Treatment, supportive care. So fluids, frequent small sips of clear liquids, water. It says half Gatorade. Don't half the Gatorade. Don't do that in your life. Right? The Gatorade is mostly what electrolyte? Sugar, right? It's not great for if someone is truly dehydrated, not great. If they're on the pitch, right, or a football field, fine, great, like go Tigers, whatever your team is. But for someone throwing up, not great. Pedialyte though, that'll fix it. Okay? Or if you want to be really gangster and nasty, you can have them open up their Gatorade and just pour their salt packet from the MRE in there, shake that up. That's a good drink. If they can handle it. If they can handle it. But you see the Sprites, the ginger ales, all the stuff that your grandmother would give you when you were sicky. Okay? There are oral rehydration solutions that are out there too that you can buy. Brat diet, it's in the literature, so I'm putting it there. No, I have an issue with the Brat diet. It's not evidence-based. And they've looked at this hardcore, they looked at the evidence, and they found that Brat doesn't work. It really does not. So what they found is we're going to pick a food to reintroduce to someone who's been actively vomiting. It should be a protein-rich broth. Chicken noodle soup. Wow, that's crazy, right? They found that in the evidence, in the data, but everyone's still like brat, brat, brat. What I tell my patients is that if you feel hungry for something, try and eat it. If it makes you throw up again, don't eat that anymore. Right? It's really that simple. Like if you're like craving the Big Mac and you want to go for it, I'm like, that's kind of risky, but like go. Right? Go for it. It's fine. Because again, nausea is not anorexia. Ginger, that is a natural remedy as well. You can use vitamin B6. There's a bunch of other things that are out there you can use naturally that are for nausea. And then don't forget, like if they need to go on profile or they need a work note, don't forget about that part of their care. Now, not everyone needs an IV. Not everyone needs one. Even if they are hypertensive, you're going to have to utilize your clinical decision making as to do we start this IV or not. Also, where are you? Are you in a family medicine clinic and you have a whole bunch of patients coming in, and now you have to take away one of your nurses to go to the treatment room just to give one patient a liter of normal saline or LR. What are you doing? If they're that acute, send them to the ER. Or are you managing them? But if you're in the ED, you ain't got nothing else to do. Right? Or you have a bunch of other patients and you still have, okay, well, cool. You've been throwing up a bit. Is anything that's gonna kill you? No. All right, give my IV. See you later, right? And you forget about that for 4.5 hours. Also fine. Also completely fine doing that. Understand that delivering rehydration is best PO. It's best. So the IV is not better than the PO. You absorb more. The electrolytes work better if it goes through the gut. You can actually drink normal saline. You can drink like the Ringers. I challenge you to try it. It's disgusting, but do it. Like just to see what it's like. I've done it. It was crazy. It was a whole thing. Yeah, it tastes absolutely crazy. It tastes like it smells, which is delicious. All right, so PO is the way to go. Generally, right, to rehydrate your patients. So if you need to give an IV, you think it's clinically indicated, by all means, push the fluids. Other things we can do, I already talked about our Lord and Savior Zofran. Multiple different preparations for this medication. It's great, has very few contraindications. There are some drug-drug interactions that you need to watch, but that's not for me to mess with now. Just know, right, QT prolongations, that kind of stuff. Where you like to send somebody into AFib because you gave them Zofran and they were on Doxy for their acne. Whoops, my bad. Right? But they'll be fine. Dopamine antagonists. So these are meds you should become familiar with. So you got Phenergan, and I'm going to put generics and brand names on the exam, so you know, because some of these I will use their generic name because I'm used to that, and some of them I'll use their brand name because it sounds more like English. So that's just for your awareness, right? You got Compazine as well. You have to be careful with those meds because some patients can get antipyramidal or dyskinesias with the side effects of stuff like shaking and stuff. So you maybe have to load them with a bit of Benadryl beforehand or some type of antihistamine. Speaking of antihistamines, Meclizine, Antivert, Benadryl, right? Dramamine. Those are all great medications because what is the 5-HT? It's a 5-histamine protein. That's what it is. Right? So we're giving them the antihistamine to stop. And these antihistamines are first generation. They're terrible for your allergies, but they're great at like interacting with other stuff. They're not supposed to. Okay, so absolutely utilize these. Another one that's not listed here is hydroxyzine or Atarax. All are great. And not only does it make your nausea go away, it puts you to sleep. That's 2 birds, 1 stone, right? You just sleep this off. You're gonna get better, friend. You fine. And then we got the anticholinergics, so that's just scopolamine. And you generally are thinking about that when someone's got like BPPV, vertigo, or whatnot. So don't forget, can they handle the PO med? If they can't handle it, like they've been actively throwing up, and your decision is you discharge with a PO med, like you're an ass, right? You are. So give it to them, correct them instead, which is the better way, right? Or you can do the oral dissolving tablets, okay? Or even hit them IM right before they leave, also fine. Questions about nausea or vomiting? All right, let's talk about the subject no one cares about, hiccups. So, involuntary contraction of the diaphragm. They involve only one in the diaphragm, left greater than right. Who cares? Who cares? Benign, it's self-limited. What can cause it, right? Gastric distension, sudden temperature change, which is funny. You go from like hot to cold and you get the hiccups, you're a weirdo. Alcohol ingestion, you've heard that, you've seen that like in Disney cartoons, the drunk is get hiccups. Yeah. And then states of heightened emotion, excitement, stress, laughing. However, hiccups do matter if they don't go away. And if they don't go away, we need to think, well, what the heck's causing this? Right? Perhaps there's some type of phrenic or vagal nerve mass there that's being irritated. Oh, that's not great. Or a mass elsewhere in the body that's affecting the central nervous system. Maybe it's metabolic. And you might see this and a patient that's intubated, right? They just randomly now have the hiccups. Right? That's bothersome for you when your nurses have, like, why are they doing this? Are they fighting? Are they trying to come back? Like, push more meds. So yeah, persistent intractable hiccups, we need a full history, full exam, determine the cause. How do we treat it? Spoonful of sugar. Stimulation of the nasopharynx. You just get a Q-tip and you just like stick it in the back of your nose, and then maybe it goes away. Right? That's what they do. Right? Valsalva. That's one thing I've seen work. When you tell a patient, like, hey, I want you to bear down really hard that you're trying to freaking squeeze out the biggest part of the world, and it'll go away. They also laugh a little, and that helps. Okay? You try rebreathing, where you're trying to breathe oppositely. You scare them. Like, seriously, you can scare them, and they'll go away. And no one knows why. But you can also use Tegretol, which is an antipsychotic. There's other antipsychotics that are out there that you can use for this. This is crazy to me. But you'll see it on the news, like on the morning shows, like, hey, she's had hiccups for 13 months. It sucks. Questions about hiccups? All right, last but not least, eructation, or belching. Involuntary or voluntary release of gas from the stomach or esophagus, typically due to aerophagia. This is really only problematic if they're symptomatic. With gastrointestinal gas, we also have flatus, which is farting. That's a clinical important question to ask, specifically in our post-op patients. You'll find that when you're in rounds, after someone's had intra-abdominal surgery, one of the first questions you're going to ask them after, like, how are you doing? How's your pain? Like, have you passed gas yet? Because we need to know, do they have a post-operative ileus or not? Because if the bowel is back to doing this normal thing, get you out of the hospital. But if it's not, you need to wait, okay, until you actually do. You'll see it especially with our Roux-en-Y gastric bypass patients as well. For any of you that are going to our bacteriatric centers of excellence, it's a constant thing. We need to know that the bowel is working, that everything's coming out again, even air. Two sources cause the flatus: swallowed air, or it's bacterial fermentation of undigested carbohydrate. Lots of gases in there, foul smelling for a variety of reasons, but mostly the hydrogen sulfide, ammonia, and methane. So if it's symptomatic, and it's causing them problems, then maybe we need to look at like a malabsorptive syndrome. And what else is going on with it? Are they having pain with it? Any nausea, any vomiting, any diarrhea associated with it? What's your food look like? And we'll talk about the FODMAPs here just quickly. Those are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And then we can try some pharmacotherapy. Right? Beano, remember those things, right? Beano you can do. Lactate, so those people who have lactase deficiency, they can take that. Gas-X, metacone, also okay, to help those patients. Here's those FODMAPs. So think of dairy products, fruits, corn syrups, stone fruits, mushrooms, legumes. So like anything that you would find at a Michelin star restaurant, like just don't eat that, and maybe you'll be okay. Just give it a try. There's even more examples there. This is just for your own knowledge. I'm not going to ask you like which of these is an oligosaccharide. That's not where we're at anymore, guys. Like we're past that. Questions on nausea, vomiting, hiccups, burping, farting. Okay, let's take 10 minutes and then we're going to get into our part 2. All right, so this is part 2 of the intro, aptly named, because we're going to talk about number 2. Right? Did that on purpose. Not that good. Surprising. We're talking about poop, guys, the rest of the time. So, Bristol stool chart. This can be a useful tool for you clinically. It's very fun to have this just hanging in your exam rooms. Because you can ask the patient, you're like, hey, look, on a scale of 1 to 7, and look at these pictures, what that poo do? And you just have a point. Right? And it gives you an idea of what you're working with. Okay? Sometimes they're super nasty, and they'll have brought a photo, and then you get to decide right, on which one it is. Oh, it's so terrible. It's so terrible. Okay, so let's talk about constipation. What is it? So you generally have to start with what is the normal bowel habit for the person, for the patient. They're defining their constipation symptoms as infrequent stools. So they're saying, hey, I'm going number 2 less than 3 times in a week. It's hard stools. It's excessive straining. A sense of incomplete evacuation, maybe what they described. Rome 4, so they actually met together in Rome, all the gastroenterologists in the world, and they spoke about poop for several days at a conference. I'm sure there's nothing else but just focus on how do we define constipation. And again, this is one of those DSM looking lists, right? 2 or more of the following. So the straining during a quarter of your poops seems to make sense. Right? Other things, they're having to do manual maneuvers, like they're lifting both legs over their heads, or they're trying to do some acrobatics, or like blowing their nose in order to get the stuff to come out. Right? So any of that weirdness, and hopefully these are intuitive to you. These are the way you normally think colloquially about constipation. Now what are our etiologies? This is more clinical. So primary and secondary. Primary is more common. Cannot be attributed to any structural abnormalities or systemic disease. Again, these patients are complaining of infrequent bowel movements, abdominal bloating, excessive straining. They may have a history of some type of psychosocial disorder. And then the secondary, this is really what we're ruling out in a lot of cases, are those systemic diseases, medications, obstructing lesions, typically more sudden in onset without any prior history of constipation. So primary, we're thinking within the GI tract, so slow, chronic transit time, IBS constipation, that's irritable bowel syndrome constipation, pelvic floor, anal sphincter dysfunction. And then we have our secondary constipation, which is outside of the GI tract. So again, endocrine, diabetes, hypothyroidism, as I mentioned before, metabolic disorders, hypercalcemia, hypokalemia. I just mentioned hypokalemia and vomiting. So you vomit so much you no longer poop. It was a real possibility in these patients. Mechanical obstruction, erectocele, perhaps it's pregnancy. There is an effect with estrogen on the body during pregnancy. We'll talk this more in block 2 when we talk about the biliary tree, but estrogen slows everything down in the gut. Then there's neurological disorders, Hirschsprung's, which is congenital, multiple sclerosis, spinal cord injuries, Parkinson's, usually multifactorial in nature. More just diseases to know about, so I already mentioned Hirschsprung's, hypoganglionosis, there's just fewer ganglions within the rectum to allow for defecation to occur. Congenital dilation of the colon, or small left colon syndrome. This is kind of niche stuff. That's nice to know. You should understand what Hirschsprung's is. Did you guys learn about Hirschsprung's in radiology? You'll see it in peds. It's just one of those things where it's a kid that can't poop, right? And you take the x-ray and their colon's just humongous, it's taking up their whole abdomen, right? Medications, what causes it? Opioids, absolutely. You've heard that before. Antidepressants can cause constipation or diarrhea, believe it or not, because most of our serotonin receptors, well, they're not in the brain, they're in the gut. And what I normally tell patients, this is an aside, I tell patients, hey, if you get constipation or diarrhea, that means the medication's working. Right? And then it'll normalize after a while. Antipsychotics, antacids, so if they're chewing a bunch of Tums, that absolutely can make them constipated. Calcium channel blockers, so from any of those meds for a variety of reasons. Iron certainly can. And dosing of iron, I know this is not hematology, but one way to get past the constipation side effect is to do every other day dosing. That'll fix it. Diuretics certainly can do this, and then overuse of anti-diarrheal medications. Inadequate fibers etiology, poor hydration, so they're not drinking enough water, they're not getting enough fiber. Know that the standard American diet, also known as the SAD, right, does not have a lot of fiber in it. So a great recommendation to patients that are coming to you complaining of constipation, step number 1, just increase fiber, increase hydration. We're already on the right track. Poor bowel habits, really holding in too long. And who holds their bowel and bladder too long? Healthcare providers. You guys, right? Because you're going from room to room. Yeah, certainly kids do as well. And then obstructive lesions, cancer. History is extremely important. And these constipation patients, it's going to tell us is this primary, is this secondary. We need to have a pretty full review of systems, getting those pertinent negatives out of the way, talking about their medications, talking about any prior history of constipation. On physical exam, you may appreciate some dullness to percussion on that left side. And why? Because they've got a very large stool burden over there. And then the DRE, now it's actually indicated. Now we're doing it to assess if there is any stool within that rectal vault. And the first time you appreciate stool with your finger on the rectal vault, you'll never forget what that feels like, what that's like. I don't have to describe it to you because you're going to do it. Not on each other here. Okay. What's the workup look like? So anyone who's over 50, now they've got this new onset constipation, we have a conversation, right? Because what should they have had by the time they're 50, regardless? Colonoscopy, right? And now they're constipated, I should be thinking, cancer. Okay. Severe constipation, and then signs of any organic disorders, any alarm symptoms, they're bleeding out of their butt. Okay? Probably have a conversation. Probably something we should consider. Weight loss, a positive fecal occult blood test, and know that, and we'll talk about this later in block 2, that's not just the guaiac that's in the exam room. Right? This is a deliberate test you order 3 different times because the sensitivity and specificity are kind of crap on it. So that's, they need to go poop on a stick 3 times and then bring it back. And then we're going to look at it. Someone's going to look at it. Family history of colon cancer, genetic loading, or inflammatory bowel disease. And what are they getting? CBC. Why? Anemia, blood, right? Like, are they bleeding? I need to know, is it bleeding somewhere? Because this is a mass now that exists in your colon, right? CMP, obviously looking at their electrolytes, looking at the liver enzymes, TSH, and only TSH, because this is constipation. I don't need to confound this with free T3, free T4. And you'll find this when you guys get into endo in a week or two. The way that we screen for hypothyroidism is TSH alone. That's it. Don't order the full panel. You'll just confound yourself and things will get super weird super fast. Radiographs, could you do them, right? Abdominal x-ray, you'll see the non-specific bowel gas patterns. And then endoscopy, either colonoscopy or a flex stick. And just some pictures, you got an x-ray there, you also have a CT. We call this, in the gallows, right, these patients are FOS, they're full of shit, right? That's what that is, they're full of stool, as you'll see. But you can see that stool burden in that CT, that's a lot. And just know that, like, they got to prep the bathroom when that comes out. You need to, like, be ready, like, have the phone charger, like, because it's going to get rough when that comes out. Okay. How do we manage it? We need to optimize our toilet habits. So timing, positioning. You guys remember there was this commercial back in the day, the unicorn, right?
Squatty potty.
The squatty potty. Okay, and they sold a little stool that you would keep. Like, that's evidence-based. Okay, that's a better way to poop. You could just have them squat on the toilet too, like they're really nasty. Like, you can do all those things, but the squatting, the positioning is a real thing to ensure that it's a nice little sled down into the water. Increase their dietary fiber, fluids. So give them a trial of the bulk-forming laxatives. You got Metamucil, Citrucil, Fibercon, Benefiber. Those are all gross. I don't know if you taste them. They're all terrible. So and you can prescribe them. You can. You absolutely can. I just tell patients, go to Walmart, go buy the gummies. Just get the gummies and make that a part of your morning routine. You drink your water, your coffee, you have your 2 gummies, you're good to go. Okay? It's a small price to pay for normal bowel habits. It's good. So the gummies are great, but you can prescribe this other stuff. They can mix it in with whatever, and it just tastes terrible. Just think about compliance, right, long term. Regular exercise. So you drink more water, you increase your fiber, get a little bit of exercise, you're off to a good start. And we'll fix that constipation. It's crazy. If you know that a medication is the culprit, then consider stopping the medication or transfer it to a different medication that can provide the same effect. Pharmacotherapy, our osmotic laxatives, these work great. Right? Miralax is great. Milk and magnesia is great. Our stimulants, this is what you should prescribe whenever you're going to give someone short, medium, or long-term opioids. Okay. It should be a stimulant laxative. That's not testable, that's a clinical pearl for you. Okay. Specifically, Docalax, Orcina, X-Lax, those are great. Because what doesn't work is DocuSafe. It doesn't work. It gets prescribed all the time. It is no better than placebo. The N that they utilized to get that through to the FDA had about 36 patients in it back in the 40s or 50s or something. It doesn't work. It's one of those things that just we do for no reason. We just give it. The mechanism of action just doesn't work. It's a placebo, so don't waste their time. It does work well if you're trying to get grossness out of the ears. Just good luck trying to pop a little pill. It's really hard. I did it, but it's just kind of hard. Mineral oil, that can do some things, but then enemas, tap water, right? Or you use the saline, they're Fleet's enema. Other agents, third line, we're going to talk more about this particular class of secretagogues. So that word needs to become part of your vocabulary. Linzess or linezolid, we're going to talk later as well. We're talking about IBS-C. That needs to become a part of your vocabulary. The opioid antagonists, so understanding enteric, another one you should be familiar with. And then the 5-HT4 receptor agonist or prokinetics, Motegrity. That's great. Anyone watch South Park? That's pretty fun. Okay. So yeah, and I'll hit on Linzess again later. I'll let you know, right? Hey, this is important. Secretagogues, important for constipation. They cost a lot of money. They do. Complications of chronic constipation is fecal impaction. And these patients can then get periodontal diarrhea. So they're so constipated that now the stool burden is so far up and proximal, so it's all the way over here, that the stool doesn't even form anymore. It's just liquid the whole way down, and they're just having this diarrhea. Crazy. Crazy the way that works. This requires manual disinfection. So manual fragmentation, and then we give them an enema, and then we stand to the side, and we let it rip. This is often done in the emergency department or while they're hooked up to cardiac monitoring. Why? Yeah, you'll vagal them down. Like, so, why did you need CPR? Well, let me tell you, that's a really funny story that you don't want to have happen to your patient. And it will be you that'll be doing it, the students, because the nurses aren't going to want to do it. So get in there, get your fingers dirty. That's strain. Okay. So long-term straining of the stool can result in chronic dilation of the veins of the rectum, and we call that hemorrhoids. We're going to have a whole lecture on hemorrhoids. When do we refer? Okay, we tried these treatments, they didn't work. Okay. Intuitive. They've got some type of structural abnormality, not your lane anymore, primary care. There's evidence of an actual obstruction. They're over the age of 50, they've got some type of alarm symptoms. They're getting the scope, okay? They're out of your hands now. Questions? Constipation. All right. Let's hit up diarrhea. So here we're asking, what is your normal? Bring up that Bristol stool chart again. Point right here. Point to where the poop looks like. And we'll look at it together. They're going to talk to you about frequent stools. More than 3 per day. 3 is a lot. It's a lot. Poop. Loose, watery stools. This urgency that they need to go to the potty. Etiologies. A billion. We're going to talk about them later. But so many things can cause diarrhea. So instead we're going to look at chronicity as a way to categorize. We're going to look at acute versus chronic, and we're going to look at inflammatory versus non-inflammatory. Now acute, that's diarrhea that's persisting less than 2 weeks. Chronic, diarrhea persisting longer than 4 weeks. And then inflammatory, think bloody, versus non-inflammatory, non-bloody. Now you may be asking yourself, so what do we call diarrhea between 2 to 4 weeks? Persistent diarrhea. It's not real. Don't worry, I'm not going to give you that window, okay? It's just this weird gap in time where either the diarrhea figures itself out or it doesn't, okay? And we end up into the chronic part. All right, so history. I need to know, is there blood? Anytime we're talking GI, whether it's coming out the top or going out the bottom, is there blood? Need to know. Have you traveled anywhere recently? Specifically outside of the country. Like, I don't care if you went to Pueblo. Like, I don't care if you, like, that doesn't matter to me. But if you went to India, let's have a conversation, okay? Diet changes. Maybe they ate in a new restaurant. Maybe they ate food they've never eaten before. Recent antibiotic use, we have a whole lecture on this, okay? And then sick contacts. Hopefully that's all intuitive for you. And then we're going to describe the severity. So mild, it's tolerable, non-distressing, does not interfere with their planned activities. They're just going like 3 or 4 times in a day, right? That's why they're coming to talk to you. Moderate, distressing, it's interfere with their planned activities. So now they can't watch the full football game, right? Now they can't watch the full Formula One race or qualifying. You guys watched that last Saturday, which I know you didn't. And then severe. Now, it's impacting or completely preventing their planned activities. And then there's an or, it's bloody. Okay, so it's inflammatory. So by definition, inflammatory, we're thinking severe. So acute, non-inflammatory diarrhea as a category. Less than 2 weeks, it's watery, it's non-bloody, mild, self-limited. Generally, it's caused by some type of virus or a non-invasive bacteria. Now, who do we work up? If it's severe, so it's literally impacting their lives, or it's bloody, I already told you we're talking about non-inflammatory, so they get worked up. Or if this diarrhea has been going on for longer than 7 days, we're going to work them up. So again, what causes it? The viruses, norovirus, rotavirus, the enteric adenovirus, it could be protozoal, so Giardia, maybe they went to a water park, maybe they went out camping, sure, right? Loose, watery stools, up to 10 per day, abdominal cramping, bloating, could have nausea or vomiting associated with it. And they might also have some signs of dehydration, orthostatic hypotension, lightheadedness, dizziness. So that's acute, non-inflammatory diarrhea, what it looks like. Acute inflammatory diarrhea, again, less than 2 weeks, but now we got blood or pus. Now we possibly have some type of systemic symptom as well, like a fever, usually caused by an invasive or toxin-producing bacteria. So now we're looking at, remember E. coli, 0157H7, remember what did that cause? Pus, yeah, hemolytic uremic syndrome, right? They call that in the kiddos. And then testing indicated for C. diff, and we'll hit that. We'll talk about the parasites later. And here are the common bugs. When you're thinking, do they have dysentery? These are typically the people that we're looking at: E. coli, Shigella, Salmonella, or C. diff. But with C. diff, within the history, there's always going to be that recent antibiotic use. Symptoms: loose, bloody stools. Now we're different, lower in volume. Again, another difference, the fever, as I mentioned. Severe abdominal cramping, urgency, and then a word that if it's not already in your vocabulary, needs to be in your vocabulary, tenesmus. That's that feeling that, oh, I gotta poop, it's gotta come out, right? And then nothing goes out, nothing actually comes. It's that feeling, that urge that they need to go to the bathroom. An acute diarrhea physical exam, typically non-specific. Okay, we're still going to palpate, right? We're still doing those things. You're still going to look in the mouth, look at the mucous membranes. You're still going to pinch the skin, all those different things. We need to assess for stuff and see if it is or is not there. Do they have distension? Do they have jaundice? How do their bowel sounds sound? The Borborygmi, that is a ding, 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 ding constantly, or is it normal? Do they have pain? Are you noticing an organic? So in the evaluation, again, we're talking acute diarrhea, the non-inflammatory side, typically self-limited, and mild. Usually labs are not needed unless we're going longer than those 7 days, or maybe it's like really severe, like they're dehydrated. On the inflammatory side, we're working it up. We gotta find out what's going on. So who's getting the problem evaluation? So signs of inflammatory diarrhea, so fever, white blood cell count of 15 or greater. So know that the upper limit, when you look at the white blood cell count, 10 is where we kind of hit it. Like if it's greater than 10, you've got leukocytosis. I'm saying 15, that's a lot. That's a whole lot. They need a full workup. You notice that there's blood or mucoid diarrhea, severe abdominal pain. It's profuse. They're older. They're immunocompromised. That makes sense, right? Exposure to antibiotics. They acquired this diarrhea while in the hospital. Hopefully all that stuff is intuitive to you. And what are we doing? We're getting a CBC. We're getting a CNP. We're looking at amylase or lipase, possibly. We're looking at fecal leukocytes. So those will be negative in non-inflammatory diarrhea. These are inflammatory markers. The fecal leukocytes, also fecal lactoferrin, another marker of intestinal inflammation. That's why we're ordering those. You get your stool culture, your O&P, 3 samples. Again, you gotta poop a bunch. They're gonna have plenty. And then that C. diff assay if they have recent antibiotic use. General strategies for treatment: we rehydrate them. PL liquids. Diet-wise, right, you can just maintain your normal diet. Avoid the high fiber foods, potentially fats, dairy, caffeine. Again, just remember how I said, return to the diet that they want to go to, and you'll be just fine. Meds-wise, what do we use? Well, for the most part, we don't do anything. We just want them to poop it out. But this is where you have to consider the whole patient and why they come to see you in the first place. This is probably impacting their job or on the military side, potential mission. So non-inflammatory, acute diarrhea, if you gotta go on patrol, here's some little paramide, go get shot, and not me, right? You're going out, not me. So consider those things, right, about when you treat versus when you don't. But for the most part, just let them flush it out. And then Pepto-Bismol. Now, even in inflammatory acute diarrhea, pharmacotherapy for antibiotics is not always indicated. Who do we consider it in? Immunocompromised people, significantly dehydrated, right? We know for sure it's not hospital acquired. They've got severe fever, they've got tenesmus, the bloody stools, they've got those positive stool inflammatory markers. These are the people that we're going to give antibiotics to. And hopefully it's obvious the type of antibiotic we give. Something that's going to attack those gram negatives. Right? We're going to utilize fluoroquinolone right off the bat. Now here, I don't care about dosaging here. Don't care about this. You can also utilize macrolide or zithromycin in these patients. Other folks that get antibiotics are those individuals that we have established have traveler's diarrhea. Now this is diarrhea that's occurring within 10 days of them returning from travel somewhere. And if we can put those two things together, we can give them Baricumedics as well. That can shorten their course of diarrhea by a little bit. Okay. And what do we typically give them? Just give them, zithromycin. Right. You can do a single dose. Just give them 1,000 mg. Rock and roll. Right. You'll be better in 7 days. Or I don't give it to you. You'll be better in 7 days. No change. Or you can use rifaximin as well. Specific treatment. Each one of those will have their own way of being treated. I'll let infectious disease do that part with you. These things aren't as common. I'm not going to waste your time with it. But we will have an entire lecture on C. diff, because that one's a bit nuanced. Who are we admitting? Severe dehydration. If that makes sense. Okay. The bloody diarrhea is getting worse. Because now we gotta get to the point where, shoot, we need to scope them now? Is a natural bleed that we need to sequester? The severe abdominal pain. They've got some issues about toxic colitis, that's for block 2. The signs of severe infection or sepsis. Folks that are immunocompromised, Jerry's, someone that has HUS, right, the hemolytic uremic syndrome. Hopefully that's intuitive to you. They look sick, like you're going to get that gestalt. Right? You're going to know, like, hey, this person's old, immunocompromised, they're not doing well, look at their vital signs, they're febrile. I'm admitting them. Right? They're just going, come into the hospital, come to the hotel hospital, we're going to watch you, because you probably going to die. Nice flow chart for you there. That's from up to date. It just says everything I said. Questions about diarrhea? And we're not done. This is just, you're going to get a taste of the diarrhea. Also should have said that. Okay. So, chronic diarrhea. Present for more than 4 weeks. And what causes it? Meds, top of the list. Right? We got some osmotic diarrheas, some secretory conditions, inflammatory conditions. We're going to have an entire lecture block in block 2 on those. This lecture block, we're going to talk about malabsorptive conditions, motility disorders, chronic infections, and some systemic disorders as well. So meds. We've got to look at all the meds. And if we can determine, like, yep, we think this calcium channel blocker is doing something to you, or we think that this diuretic is doing something to you, even though we thought initially it was for constipation, and now we think maybe it's bad. Sure, give it, but stop it. Maybe switch classes. Okay? If we, like, hey, why are you taking this erythromycin? Like, I don't know, well, maybe let's stop it. So we'll have to do a thorough review, look at the side effects of the medication. And I'm not giving you any here, right? And those examples I just gave you were trash, but I'm just telling you, look at their meds. And then don't forget to ask about OTC meds, herbal supplements, and other supplements. So you've been having diarrhea for 4 weeks. Okay. Have you taken any supplements? Take creatine. Okay. When did you start taking creatine? 4 weeks ago. Okay. Well, that's by itself an osmotic laxative, right? And so you will know that. Your body eventually figures itself out. Those are the kinds of things you talk to your patients about. All right, osmotic diarrheas. Things that are specific to this category of a chronic diarrhea. Increased stool osmotic gap, and I'll show you what that looks like here in a second. And then importantly, it resolves when the patient fasts. Etiologies, we've got carbohydrate malabsorptions, some laxative abuse, and who abuses laxatives? Who? Potentially, right? Bulimics, right? More than the anorexics. But folks that are like trying to lose weight, right? When it's take time for the military, yep, they may try it. Okay. And then some malabsorptive syndromes. We'll hit, that'll be a whole lecture. So there's that stool osmotic gap. So we're looking at the differences between the osmolality of the serum and the feces. And you can do math. I know we just recently talked about using calculators on exams. You will not use a calculator on mine. If you do, you're wrong. If you thought about using a calculator, and we're talking about poop, you're in the wrong class. Unless you're going to show me some like clever thing you spell a word, then okay, I'll laugh with you. Right? But there's no, you're not calculating this. What I want you to know is the why behind it. Okay? And back to this slide, osmotic diarrhea, you have increased stool osmotic gap. So if I tell you the osmotic gap is high, and I give it to you in millimoles there, that's important. Okay? And I always give you a normal range. So high, osmotic. Okay? Low, secretory. We'll talk about that one next. And I'm not going to give you anything that's equivocal, because what fun is that? I can't make 4 different answers. No. But you can do that. You can take the poop, and you can math it. All right. Moving now to our secretory conditions. So these are increased intestinal secretion or decreased absorption, high volume, watery stool, low stool osmotic gap. Again, differences. Another thing that's different, little to no change with fasting. So that's how these patients are going to present in the vignettes. Okay. Etiologies, alcoholism, right up there, right? Stimulant laxative abuse, endocrine tumors, sometimes people that are post-surgical, either post-cholecystectomy or they could be post-Roux-en-Y gastric bypass, hyperthyroidism, and microscopic colitis. Not very common, that final. Our inflammatory conditions with chronic diarrhea, we're going to have an entire lecture series on these for Crohn's and ulcerative colitis. We're going to hit those. I'm going to be able to show you why one looks like this way and one looks like this way. It's going to be clear to you. And then I'm going to brush over microscopic colitis because it's not common. Motility disorders, those are irritable bowel syndromes, pain and altered bowel habits. Again, we're going to hit that up hard later for this block. Malabsorptive, also we're going to talk about celiac disease, Whipple disease, tropical sprue, all those different things we're going to hit on, so you will understand these as diagnoses and how they present. And trust me, there will be something key to every one of those. You'll be like, okay, cool, I know how it's going to present. Parasitic infections, we don't go into too much, but this is why we're doing those O&Ps. We're getting those 3 different stool samples. We're looking for Giardia. Remember Entomia histolytica, one of my faves. Cyclospora, those intestinal nematodes, they're really nasty stuff. Like people love that, it's so rare. But common elsewhere, but it's not common here. And then those systemic conditions, so don't forget about your thyroid, right? Which angle of the spectrum we're with in the thyroid. So what is hypothyroidism? We're thinking constipation. Hyperthyroidism, we're thinking diarrhea. That needs to be stuck in your brain as you do your review systems, and as you take my exam. And then diabetes can cause chronic diarrhea as well. It's like it can cause chronic constipation. It crosses both worlds, unfortunately. Generally though, and the diabetics, it's secondary to their medication. Specifically metformin. That will give you the boost, if you will. So what do we see? Is this continuous? Is it intermittent? Do they have the diarrhea in relation to meals? Are they pooping a bunch at night only? That's strange. Is it occurring during fasting? We're asking that specifically to differentiate secretory versus osmotic. We talk about the appearance of the stool. Look at that Bristol stool chart. Is there blood in it? Do they have pain? What meds are they taking? Have they had weight loss? And then the psychosocial part. And that will become important again as we get into the IBS-C versus IBS-D. Lung features, this is a kind of consistent theme. Your past colonoscopy, and now this is happening. Worried when you look into this. If there is blood, strange. The nocturnal part, also strange. You're just pooping at night, what? Does that make sense? The progressive abdominal pain, any of those B symptoms, any lab abnormalities, so they've got diarrhea, oh, and you found out they're anemic, need some more workup, right? These are alarm bells. And then any genetic loading, so inflammatory bowel disease or colorectal cancer. So first, when we're working this up, we exclude those most common causes, the medications, the inflammatory bowel disease or inflammatory bowel syndromes, food intolerances. Lab tests, it's not a shotgun, it's all deliberate. We're looking at CBC, so look at their red blood cells specifically. I'm also wanting to appreciate whether or not there is some type of inflammatory process happening with the white blood cells. I'm getting the CMP to look at their electrolytes, to look at their liver enzymes. I'm getting the TSH and possibly a T3, T4, right, because I'm thinking hyperthyroidism. I'm also getting some other inflammatory blood serum markers, an ESR or CRP. You don't have to get both. Getting celiac tests, stool studies, right? They're pooping in bags for days for me with this. They're gonna get colonoscopy, right? Gonna get a colonoscopy because we've now got to rule out. We've got to take tissue and see what it looks like and rule out those other bad things like Crohn's or ulcerative colitis, okay? Or potentially this cancer. You can do a 24-hour stool collection. We're looking at the total weight, the total fat. And mind you, like anytime you're telling a patient to collect these things, they also have to transport it. They have to buckle it up, right? So when you say do a 24-hour urine, they had to buckle that jug up into their car. So like remember, if there's another way to assess it, you can do that. Don't then they have to walk to the hospital, a little walk of shame. Right? Everyone knows what's in there. It's disgusting. Like don't do that to them. Sometimes you have to though. Sometimes you gotta take their poop. Sometimes you got to. Treatment, depending on the etiologies. Again, those antidiarrheals come up. Kim's codeine. That's funny. Your chronic diarrhea. Like, here's the lower tab, like, great, that's great. Clonidine can be utilized, it's a blood pressure med, but especially for those that have diabetes, which is kind of strange. And also for those secretory diarrheas. Octreotide, we'll talk about that later when we hit up the esophageal varices, but that can cause a whole lot of vasoconstriction and they help with the diarrhea. There's biosulfiders, but anybody that's getting chronic diarrhea workup, they're on their way to go see GI. Okay. So that's everything I just said in a chart for you chart people that are out there. What questions do you have about chronic diarrhea?